Hello, my name is Fiona Mara. I'm a Hep C pharmacist from Glasgow and I'm part of the Liverpool Drug Interaction website team. So today we're going to look at a co-infection case. And the learning objectives are to understand how to assess for DDIs in a co-infected patient, to think about the choice in changing either the antiretrovirals or the directly acting agents to get around the drug interactions, to understand how to assess other co-medications within a co-infection scene, and to understand the importance of assessing liver disease severity in a patient with co-infection. So let's have a look at our case. This is patient JK. He's a 49-year-old MSM diagnosed with hepatitis C and HIV in 2013. He's currently on darunavir cobicistat with Truvada. His CD4 is 560 and he has an undetectable viral load. For hepatitis C, he's genotype 1A. His PCR is 437,000. He has a FibroScan of 24.2, which is F4, and he's been categorised as Child-Pugh A. And he's previously failed treatment on sofosbuvir, interferon and ribavirin. So the first thing to think about with these patients is, do we choose a combination to fit around the patient's antiretrovirals, or do we choose our DAA of choice and change the antiretrovirals to fit around with that? So let's have a look at the drug interactions to see if that helps make the decision easier. So if we look at all the currently licensed agents for the treatment of genotype 1 hepatitis, and currently licensed agents for the treatment of HIV, we can see that there's quite a lot of drug interactions that we need to think about for different agents. And this table looks at the NRTIs and the NNRTI groups of HIV antiretrovirals. So we can see across the board, looking at the different DAAs, that we do have red combinations. So these would be not recommended or contraindicated. And we see here, because of the NNRTIs, it's likely due to the induction because of the efavirenz or other NNRTIs, where we have not recommended with Sofvel-Vox, glecaprevir, prevrentisvir, simepravir, elbasvir, grizoprevir, the ABV3D combination, and sofosbuvir, velpatasvir, and some other ambers in as well. What about other HIV drugs? So if we look at the protease inhibitors and the integrase inhibitors, again, lots of interactions that we have to think about. So red interactions across the board with protease inhibitors, again with 3D, looking at darunavir cobicistat. So we see here our patients on darunavir cobicistat. We have a red interaction for 3D with elbasvir, grizoprevir, with declatasvir, simepravir, and glecaprevir and prevrentisvir. So if we're looking for an agent that we can use with the combination of antiretrovirals that our patient is on, we can see that the green options are sofosbuvir, velpatasvir, and sofosbuvir ledipasvir. Everything else, because of the combination of darunavir and cobicistat, is a red interaction. So that leaves us with these three. So can we choose one of these three options to go ahead and treat our patient? They're not green interactions. Some of these are amber interactions. So why are they amber? What does that mean? So they're amber because of a potential increase in tenofovir levels with darunavir in combination with NS5A inhibitors, ledipasvir or velpatasvir. And that's because of a PGP inhibition drug interaction. So if we look at the data and the licenses, we can see that this interaction has been documented both for Harvoni and for Epclusa. So we have what we call a double boosting effect. So the darunavir that our patient is on increases tenofovir levels, and the ledipasvir or the velpatasvir further increases the tenofovir levels. So you have a double effect on the tenofovir. So this interaction, as long as we do normal renal monitoring, which we would do for any patient in tenofovir, can, in a majority of patients, be manageable. However, with our patient, we can see that the eGFR has already been reduced. So the eGFR with this patient has been stable at 52 mils per minute, around this for around 6 months. So there's already a burden on the kidneys with a reduced eGFR like that. So bearing that in mind, with our 3 options that we had for our darunavir-cobicistat interaction, the 3 sofosbuvir, velpatasvir, sofosbuvir, ladipasvir combinations, because of the reduced eGFR, the decision was made with this patient that the combination that they were on for treating their HIV, there was ultimately no real good combination for DAA therapy that didn't have some issues that perhaps we couldn't get round by just switching the HIV combination. So that's what we did with this patient. So instead of choosing a DAA that might be compromised, or we'd have to do additional monitoring or put extra tests for the patient or extra monitoring, we decided ultimately to change the ARV combination. So what did we do? We changed the antiretrovirals to abacavir, lamivudine and dolutegravir. So we went for the triamet combination here to get around the drug interactions with most of the DAAs. So now let's look at the tables again, and we can look at the abacavir and lamivudine, and we can see that they're just green interactions, and the dolutegravir, again, green across the board for this interaction. So this means that when we're treating or looking to treat this patient's hepatitis C, we can choose any of the currently licensed agents that we want for genotype 1 hepatitis C. But of course, our patient doesn't just have hepatitis C and HIV. There's other co-medications that come into play that we need to consider. So this patient in particular was on treatment for chronic urticaria, and because of that was on cyclosporin at a dose of 100 milligrams, and also on montelukast, fexofenadine, mebeverine and ranitidine, all for the treatment of this chronic urticaria. So let's have a look at the drug interactions we need to think about with the directly acting agents for hepatitis C and the other drugs that the patient is on. And we can see here again some red interactions that we need to think about. Cyclosporin is a drug that is very prone to being the victim or perpetrator of drug interactions. So anytime we see it, we know there is the likelihood of issues that will come up with it. And some amber interactions with fexofenadine and ranitidine. But the cyclosporin is the drug that we need to look at in a bit more detail. And what are the interactions? Well, it's largely transporter interactions that are the issue with cyclosporin. It's a OATP1, PGP, and also some CYP3A4 inhibition that all come into play to cause some quite significant increases with some different DAAs. So if we have a look at the red combinations that we wouldn't use with cyclosporin, cimeprevir, grazoprevir and voxilaprevir are 3 protease inhibitors that you can see give some quite significant increases in the Cmax, so 15-fold and 19-fold for grazoprevir and voxilaprevir, and that's why these combinations are not recommended. Amber interaction with glycaprevir and paritaprevir. So with the paritaprevir, there's a recommendation to use 1/5 of the dose, and that's because the cyclosporin area under the curve increases 5-fold, so there's a quite specific dose recommendation there. With the glycaprevir, it's a slightly different interaction, so it's cyclosporin affecting the glycaprevir. However, this is a dose-dependent interaction, and at a dose of 100 milligrams, the increase in Cmax is just 1.3. So that is within the clinical parameters of acceptability. However, higher doses of cyclosporin give higher levels of glycaprevir. So if the patient was on higher than 100 milligrams, we wouldn't be able to use this combination. But because it's relatively low dose cyclosporin, we could consider the glycaprevir-pibrentasvir combination for this patient. And the green interactions with cyclosporin are the ladipasvir, the declatasvir and the velpatasvir combination, so we can use them. But we mentioned at the start of this case that our patient was a child's A serotic, so they haven't yet got progressed to decompensated liver disease, but they are cirrhotic, they have a high FibroScan, and they're currently sitting with a child's A score. But we need to kind of keep a frequent eye on this, check the patient's bloods regularly to make sure their liver disease is not progressing. And that's because, particularly in HIV, when we have a lot of antiretrovirals that are heavily liver metabolised and hepatitis C agents that are heavily liver metabolised, we have an extra burden on the liver with cirrhotic patients. So if you see here the drugs that are contraindicated or not allowed if this patient progresses to child B or child C cirrhosis. So the drugs in red here, which are all the protease inhibitors licensed, can't be used if this patient's cirrhosis progresses. So whilst we've analysed the drug-drug interactions between hepatitis C and HIV and the other co-medications, we also need to think about this when making a choice of therapy. And if this patient's liver disease progresses, we can only use sofosbuvir containing regimens with vilpatasvir and ladipasvir, because these are the only ones currently licensed for patients with child B or child C cirrhosis. So currently our patient is child A, and that's fine, but it's really important that we have this table and these parameters in mind as our treatment progresses with this patient, or if we don't treat him straight away. So in summary, HIV and hepatitis C drug interactions continue to be problematic even with the newer agents. Patients with co-infection often have other comorbidities and concomitant medications that we need to consider. DDIs between hepatitis C directly acting agents and HIV antiretrovirals can reduce clinical efficacy and lead to unwanted adverse events. And patients with cirrhosis need their child's Pew score assessed to allow for the safest drugs to be chosen for the treatment of hepatitis C, particularly in the setting of co-infection, because of the added burden to the liver with the HIV and the addition of the hepatitis C drugs.